they'll use IV Kytril, IV Zofran, a lot of antiemetics to try to prevent them, or they'll have them be on like a steroid taper to prevent the nausea. Okay, so remember when I said cancer cells act on any rapidly dividing cell. So if you think of in your body, what cells are the most rapidly dividing? Your hair, right? Your hair grows, you have to get haircuts because those cells are rapidly dividing, right? Any mucous membrane. So the lining of your GI tract, the lining of their abdomen, so that's why they have GI issues. So skin, nails. So sometimes they'll have rashes, sometimes their nails will get really brittle, or sometimes their nails will either stop growing due to chemotherapy, and then that's why they lose their hair, okay? So we'll talk about some of these different chemotherapy drugs. I'm going to show you a video here, if it works, that talks about the main ones, and these are ones that I have seen on the NCLEX. So
happy to level up our end. In this video, I'm going to continue my coverage of immune system medications. Specifically, I will be talking about medications used for cancer. Be sure to stay till the end of the video because I'm going to give you guys a quiz to test your knowledge of some of the key concepts I'll be covering in this video. Also, if you have our pharmacology flashcards, pull those out so you can follow along with me. It definitely takes repetition to learn this information. And before I get started into talking about specific medications for cancer, I wanted to go over some side effects that are common across many or all of the medications I'm about to cover. So one side effect common to every single one of these medications I'm going to cover is gastrointestinal upset, so nausea and vomiting. So as the nurse, you're going to want to provide antiemetics to your patient prior to administration of these medications. You don't want to wait until nausea and vomiting is happening. Also, many of these medications have a side effect of alopecia, which is hair loss. And then also many of these medications have a side effect of bone marrow suppression. And this bone marrow suppression causes anemia, neutropenia, and thrombocytopenia. So we're gonna have decreased red blood cells, white blood cells, and platelets. So what does this mean for your patient? Well, that anemia may cause them to have shortness of breath and be fatigued. They may have pallor. With neutropenia, because we have decreased white blood cells, your patient's going to be at higher risk for infection. And with thrombocytopenia, your patient will have decreased platelets, which puts them at risk for bleeding. So I just wanted you to keep these things in mind so I didn't go through the same information over and over when we go through these specific medications. There are obviously hundreds and hundreds of medications that could be used to treat cancer. I'm going to go through 6 specific medications that I think are most important to know. I'm not going to go through all the details that you can find on our flashcards, but I will definitely try to hit some of the highlights. The first medication I want to go over is doxorubicin. Doxorubicin would be used to treat solid tumors. Side effects of doxorubicin include GI upset, alopecia, and red discoloration of the patient's urine, sweat, and tears. This medication also carries a black box warning due to the risk for bone marrow suppression, cardiac toxicity, and it could also cause the patient to get leukemia. So definitely a potent medication with some very serious side effects. In terms of nursing care, you're going to want to monitor the patient for infection. You're definitely going to want to monitor their cardiac function as well as their CBC levels. In terms of our cool chicken hint for how to remember this medication and some of the key side effects, if you look at doxorubicin, it's got that ruba, like ruby, which is red. And if you remember that ruby means red, then that will help you remember that this medication causes red discoloration of secretions. Red can also help you remember that this medication can affect the heart and cause cardiac toxicity. Our next medication is vincristine, which is used to treat a variety of tumors and cancers. It does not cause bone marrow suppression, unlike a lot of other cancer medications. However, it does cause peripheral neuropathy, as well as GI upset and alopecia. It also carries a black box warning due to the risk for phlebitis, which is inflammation of the vein at the administration site. So our little cool chicken hint for remembering this medication and a key side effect of this medication, if you look at vincristine, it starts with vin, which is, it means wine in French. So if you drink too much wine, you won't be able to feel your arms and legs. So that helps you remember vincristine causes peripheral neuropathy. Okay, next we have cyclophosphamide. This is also used to treat a variety of tumors and cancers. It does cause bone marrow suppression. Other side effects include GI upset, as well as alopecia. And the unique side effect with this medication is that it causes hemorrhagic cystitis, which is inflammation and bleeding from the bladder. So in terms of nursing care, you're going to want to advise your patient to increase their fluid intake to help counteract that risk for hemorrhagic cystitis. Also, you're going to want to monitor the patient's CBC levels, and anytime you're administering this medication, you want to wear gloves and immediately wash your hands after administration. So I don't have a little trick for remembering cyclophosphamide. So if you do have a trick, then definitely leave it in the comments. The last medication I want to cover in this video is interferon alpha 2B, which is a medication that is used to treat cancers as well as viral infections such as hepatitis. It works by enhancing the body's immune response to tumors or viruses, and it helps to slow cancer proliferation as well. This medication has many side effects, including flu-like symptoms, which includes fever, chills, malaise, fatigue, and like body aches. It can also cause bone marrow suppression, cardiotoxicity, hepatotoxicity, dyspnea, so difficulty breathing, alopecia, and GI upset. As if that wasn't enough, it also carries a black box warning due to psychiatric, autoimmune, ischemic, and infectious disorders. So very serious medication with some very serious side effects. So nursing care will include monitoring the patient's liver function, their cardiac function, and their blood levels as well. Our little cool chicken hint for remembering this medication is that interferon interferes with cancer by enhancing the body's immune response. All right, time for a quiz. I have 3 questions for you. First question, what cancer medication causes red discoloration of the urine, sweat, and tears?
What is it?
The answer is doxorubicin. Question number 2, what discoloration of the urine, sweat, and tears? The answer is doxorubicin. Question number 2.
We're gonna shut her off. So those are the main ones that I've truly seen on the NCLEX, where sometimes they'll put the drug class, so they'll put like an anthracycline. So if you looked on your sheet of those, which one, oh no, anthracycline, alkylating agent. So they'll say like an alkylating agent given for whatever cancer, what is the nursing intervention? So if you had no idea what an alkylating agent was, or you don't remember this lecture at all, what is probably the most common side effects? GI. So if it's something with nausea and vomiting, I'd pick that one first. Or bleeding over nausea and vomiting, I'd probably pick the bleeding, because that's gonna kill them first, right? Okay, so I would maybe keep this PowerPoint, and when you guys are studying for your NCLEX, go over that again. Because those are truly the main drugs I've seen asked about on the NCLEX. And a lot of times they're just as a distractor, because you guys truly won't ever give any chemotherapy unless you are chemo certified. Like you have to be a chemo certified nurse to give chemotherapy. So you'll never give it in practice unless you work specifically in oncology. And you don't see a lot of chemo drugs given in the hospital, inpatient, as much anymore. Just drugs for like acute leukemics, or if they start their very first treatment. Some clinical trials, they start them first off in the hospital, but most drugs are all given in an outpatient cancer center anymore. But those are the main ones. That doxorubicin, it is red in color. It's a red drug, so it's, when they bring it, it's red. So it's infusing red into their port. Okay, so imagine being a patient, knowing you're getting poison, and it's bright red in color. Cancer patients will call it the red devil. It makes them very, very sick. It causes major nausea. It can cause cardiac toxicity. There's a lifetime maximum dose that they can have, because they know if they go over that, it will damage their heart. So what do you think they get done prior to getting this drug and throughout their treatment? Echoes. Not EKGs, they do an echo, because it will potentially affect their cardiac output if they get too much or heart damage. So they have to have a baseline echo, and then usually every 2 to 3 cycles, they'll repeat their echocardiograms to make sure we're not doing any damage to their heart. Okay, but sometimes it can happen down the road, even after they've had their treatment. They can have long-term cardiac toxicity. So that's important education for the patient. Okay, all those drugs they said cause hair loss. Vincristine is a vesicant, so that means that if the vein infiltrates, it can cause major damage to the tissue surrounding it. So a lot of chemo drugs, that's why they're given through a central line or through a portacath. You'll see the majority of patients in the cancer center have a port, because most of the drugs are too hard on the veins to give without putting it through a port. If it is a vesicant, so it has that potential of ruining the vein, as they're infusing it, the nurse has to check blood return. Some facilities every 15 minutes, and some are every 30. It just depends on the protocol. Because if you don't have blood return from their port, you cannot administer that drug, because you could truly do some major damage to their veins and to their skin if that extravasates. So if that leaks outside the blood, or outside the blood vessel, okay? So some other things, low blood counts. So if they have low platelets, we have to monitor for what? Bleeding, right? If they don't have, if they have low blood counts, low white blood cells, we have to monitor for infection, okay? Anybody getting chemotherapy, very high risk for being neutropenic. So meaning that their absolute neutrophil count, their ANC, is less than 1,000, okay? A lot of patients, if their ANC is less than 1,000, they'll end up in the hospital getting IV antibiotics. And they'll do a chest x-ray, they do a urine sample, and they do blood cultures, because they want to see, do they have a UTI, do they have a blood infection, or do they have pneumonia? Because those are usually the 3 big infections that potentially they could go septic very, very quickly, because they don't have any white blood cells to fight off whatever is brewing in their system. Sometimes if you have large bulky tumors, they can give people fevers just from the tumor itself, just from that high metabolism in the body. So sometimes they'll rule out everything, and if they don't see any active infection and their ANC is okay, they'll send them home, okay? So this slide just kind of goes through some of the alkylating, anti-tumor, anti-metabolites. Hormone and hormone antagonists we'll talk about when we get to breast and prostate cancer. So those are given for, like for instance, estrogen feeds breast cancer. So after they've gone through their treatment, they take a pill for 5 years that blocks estrogen. Okay, those are the hormone ones. We'll talk more about that when we get to breast. There's a lot of new targeted therapies that work directly on a protein on the tumor cell. And then kind of the new therapies is immunotherapy. Or for like lymphoma, leukemia patients, there's something called CAR-T therapy, where basically they take out the person's T cells, they send them to a lab, they mix them with a drug called chimeric, which is where the CAR part comes from. They infuse them back into the body, and that person's T cells mixed with this drug is smart enough to go to these cancer cells and shut off the mechanism that's feeding them. And this has saved tremendous amount of lives in patients that normally would have died. So CAR T therapy is becoming a huge thing. It's given in the hospital. It's very, very expensive for patients. It has a lot of side effects. So I'm not gonna go into that. I don't think NCLEX would ever test you guys on CAR T yet because it's still really, really new in the cancer world. But it's made big strides. But there's a lot of new immunotherapy, so a lot of drugs that are out there on the market, and these basically trick the body's own immune system to fight off the cancer itself. So these are a lot different than chemotherapy because it's not poison, it's not toxic. It is using, basically, they're usually given in pill form or sometimes IV form, and it revs up the body's own immune system to fight off the cancer itself. But because you're revving up the body's immune system, the main side effects is any sort of itis. So they can get pancreatitis, they can get thyroiditis, they can get gastritis and have ulcerative colitis. So they can still have some severe side effects, but usually it's a lot better tolerated than chemotherapy, and patients aren't getting as sick, they can tolerate it better, and they're living longer with immunotherapy. So it really is kind of the new treatment. I think for some cancers, it probably will become the standard of care at some point in the cancer world, which is pretty cool. Like melanoma. Melanoma is a drug or a cancer that doesn't respond to chemotherapy. It outsmarts it. So people with melanoma, there was no answer for them. If you had stage 4 melanoma, you got your affairs in order because you were gonna die within 6 months, regardless if you were 18 years old or 60 years old. Now with immunotherapies, they can use the body's own immune system to attack melanoma, and people are living 10 plus years. So it's pretty significant. But you have to educate them on, they can get a lot of rashes, a lot of GI upset. They have to monitor their thyroid sometimes because it can cause that to go out of whack. They can become diabetic if they get severe pancreatitis. So any itis is kind of the bad thing with immunotherapy. Okay, so if somebody is getting a vesicant, so this is chemotherapy that will eat away at normal healthy tissue. So if their IV infiltrates, this is what it's gonna look like. It will eat away healthy tissue very, very quickly. Okay, I have seen people who had just because they had a port, maybe their needle came out enough, or they had a leak within their catheter, and chemotherapy leaked into their chest tissue, and I've seen people who've had a huge plastic surgery because they had extravasation so badly. Very, very serious. So if this happens, if you were the nurse giving chemo and they started to complain of burning and you noticed they had an infiltrate, what would you do? Stop the infusion. They would actually take a syringe with a needle on it and poke it into the tissue and try to extract out some of that drug if they can. So you try to aspirate it out. If it was a big extravasation, there is certain antidotes they can give. You guys don't need to know that, just know you give an antidote, and then they put ice to the site. Never heat will make it worse, so it's always ice. And then they monitor. They'll usually also draw around the site with a marker to make sure that that's not gonna keep eating away at healthy tissue. But if you Google some extravasation pictures, you will see some pretty gnarly pictures that have happened to patients where chemo has extravasated inside their chest and have had to have major. So that's why the importance of blood return is so critical with anyone with a port or anybody getting these drugs, these high sensitivity drugs, because they can literally destroy tissue pretty quickly. So it makes sense if you see this picture, if this is what it can do to skin on the outside, why people get so completely sick with chemotherapy, right? Imagine your gut on the inside. It's why they get super nauseous, vomiting, have ulcers, pain. It does this to the bone marrow, right? So you don't have any red cells, white cells, platelets. Okay? So chemo can truly affect every part of the body. This slide is kind of hard to see, but truly, it does affect every part of the body. So anyone who's on chemotherapy, they get what's called chemo brain, where it can kind of affect their concentration. They get kind of this foggy, like brain fog, where their thinking's not always right. It is a true thing called chemo brain. There's true research that backs this. It just happens kind of through the duration of their treatment. Obviously, they can get anxiety and depression, or the psychosocial aspect of it. I've sat with patients in their first chemo infusion who truly were about ready to have a panic attack as they watched this chemo dripping closer and closer to them. Because it's very scary. If you're sitting in a chair and someone tells you you're getting poison that's going into your bloodstream, and guess what? You're gonna lose your hair, you're gonna vomit, have diarrhea, have pain, you're gonna feel horrible for a couple days. But yep, let's sign me up for that, right? So there is that psychosocial component. Some people it's very, very hard to get chemotherapy. Okay, it can be hard on the heart. Some are very cardiotoxic. We already kind of talked about that. Some have a lifelong dose. If they exceed that, it can affect the heart. There's some drug, there's a drug called bleomycin that they have to do pulmonary function tests before they can ever get this medicine, because it's very hard on the lungs and it can actually damage the lung tissue. It's given for sometimes lymphomas, leukemias, and testicular cancer. So that's a drug that sometimes will damage the lungs. Nausea and vomiting we already talked about. It can affect the nails. There's a drug they give for breast cancer called Taxotere or Taxol that will literally stop the growth of their nails, just like hair loss. Your nails are rapidly acting cells. So when you get chemo, it stops it. When they start recovering, their nails start to grow. So these people will have these deep lines in their nails, and literally if you count the lines, that's how many chemo treatments they've had. Because really when they get the chemo, it stops that growth, kind of damages that nail. As the chemo gets out of their system, the nail starts to grow, the process goes over. So it can damage nails. Loss of appetite, we already kind of talked about some of the nutrition stuff. Sexual dysfunction. They also excrete these drugs through bodily fluids. So sometimes that's the big elephant in the room of, you might have young people or people who are very sexually active, but they're going through chemotherapy. It's important that they still have that intimacy with their spouse. So as cancer nurses, sometimes you have to have those hard conversations of, if they do choose to have sex right after chemo, which usually they're not gonna feel well enough, they should definitely wear protection to prevent their partner from being exposed to that chemotherapy, because it's gonna be excreted in their bodily secretions. And usually it's for about 72 hours. They used to tell patients to double flush their toilets, to make sure they put the lid down. They don't really do that as much anymore because it's not enough excretion where it's exposing people in their house to harm them, okay? But it can cause sexual things, skin sensitivities, they can get rashes, they can get dry skin, especially immunotherapy, lots and lots of rashes with that. They'll take Benadryl, hydrocortisone cream, sometimes they have to go on steroids to kind of calm that down. They can have urinary problems, digestive problems, lower their blood counts. We already talked about, a lot of people will get horrible mouth sores because, again, the inside of your mouth is a mucous membrane, rapidly dividing cells. So a lot of times they'll have patients chew on ice, same concept as the caps, because the ice kind of helps protect the lining. So there's certain drugs they'll have patients, as they're getting chemo, to chew on ice or suck on ice, and it helps prevent mouth sores. Mostly for drugs that they get when they're on colon cancer. They're also, sometimes they'll wrap their feet in ice to prevent neuropathy, because that's a huge side effect for not just vincristine, but some other drugs, where they'll get severe numbness and tingling. And sometimes if they get enough nerve damage, they'll have that long term. So it can potentially have long-term neuropathy. Now what if they're diabetic and they already have neuropathy? Then sometimes they'll have to give them a lower dose, or they'll have to pick a different drug. Okay? So let's talk about radiation a little bit. So chemo is liquid or pill form, goes into the IV or they take it orally. And then some people get radiation therapy. So this is protons or electrons that is given normally externally. So when we go to the cancer center today, I'll show you guys kind of the radiation suite. When you guys are there, hopefully you'll get to see a patient getting radiation. So it's a localized treatment. It's used in about half the cases, so we can use it to shrink tumors. We can use it to get rid of some tumors. A lot of times it's used for people who had cancer, they remove the tumor, and now they're radiating where the tumor was to prevent it from ever coming back. That's probably the biggest way it's used. For like brain tumors, it's used for that. Breast cancer, colon cancer, you get radiation to what's called the tumor bed, okay? Sometimes they'll do it before surgery to try to shrink the tumor down. So if somebody has a really large, bulky tumor and it's gonna be too risky to go in and remove that, they'll try to shrink it down first with radiation so it's safer for them to have surgery, or they'll have it afterwards. Sometimes it's used for palliation, so if somebody has a really large tumor, maybe sitting on their spinal cord and causing numbness and tingling or causing severe pain, they might give them radiation to that spot just for pain control. Okay, so here are some pictures of some radiation. So this is a machine like they have at most cancer centers. So they're a large machine that goes over the person's body, and radiation beams come out of that machine. Okay, so if somebody had a lung tumor, a big tumor in their lung, and they were gonna get chemotherapy to kill it, but they were also gonna give them radiation at the same time to kind of shrink it. Sometimes they'll do them together, it works better. They would go in for what's called a CT simulation. So they would take their CAT scan that they had that helped diagnose this tumor, and they'll take a CAT scan on this machine. So this machine not only gives radiation, but it can also serve as kind of a scanner, okay? They fuse those images together, and then that's how they know exactly where to treat. So on the patient, they will actually place little tattoos on the patient's skin. So radiation therapists use like a little tattoo gun, and they put tiny little marks where they're gonna line their beams up. Those marks will forever be there. They're very, very tiny, very pinpoint. So it's not like they come out with this nice gray tattoo. It's a very tiny little mark, but it is truly a tattoo, okay? So then they line them up, and then they know exactly where they're gonna treat. So if you're treating a lung, some considerations, they have to make sure they're not hitting healthy tissue. So if it's really close to the heart, they have to line up their beam so they're not gonna damage the heart, okay? Or if you're treating somewhere in the abdomen, they don't wanna damage the colon, because then you can cause them to have like severe colitis or other infections. So most of the time, treatments will take anywhere from maybe 10 to 20 minutes, depending on what they're treating. But radiation is dosed in what's called gray. So G-R-E-Y is how radiation is dosed. So a radiation oncologist, a dosimetrist, some very smart brains come together and they figure out what dose patients need to effectively treat that tumor, to shrink it or kill it. And so these patients say they're gonna get 5,000 gray of treatment. They can't just come one time and then they zap them with 5,000, because you'd burn the crap on their skin, right? So they split that over several treatments. So patients who are going through radiation, they have to go Monday through Friday, same time, every day, until they get to their dose that they need, okay? So we'll talk about this a little bit with breast cancer, but if you think about, if you lived in wherever, 2.5 hours away from a radiation center, and they told you, well, you can either have your whole breast removed and you won't have to have radiation, or you can have just a lump removed, but you have to drive 2.5 hours one way for a 10-minute treatment, that might determine their surgery plan, right? So it's pretty short treatment. They don't feel anything while they're getting radiated. They don't glow in the dark. They're not radioactive while they're getting radiation. Those are all myths. And things that patients would ask me, like, is it safe to be around my dog when I go home? Is it safe to be around my grandkids? Yes. They're not radioactive when they get external beam, which is what this is, okay? So it's a beam, comes down, zaps the tumor, they're on their way, okay? So some of the side effects they can have is fatigue is a big one, because again, we're killing this tumor from the inside out, so their body's working hard. So fatigue, big side effect. They can have skin irritation, because this is a beam that's going through their skin. So sometimes it looks like a sunburn, okay? The radiation will go in, and sometimes it comes out the back. So somebody has their lung radiated, they might have irritation to their back. If it's a breast and breast tissue, it'll just be confined to that tissue on the breast, okay? But it looks like a sunburn. You have to educate them on like no soaps, no lotions, nothing can be on that skin prior to the treatment. Because if you use lotion, there's chemicals in lotion, right? And this radiation is going to interact with those chemicals, and you can actually burn your skin worse. So no deodorant, no lotions or anything that has perfumes or chemicals in it, really nothing on the skin prior to radiation. Now if their skin gets really dry and they go home that night, they can put like Vaseline or non-scented lotions over their skin, okay? So that's external beam. They also have what's called high dose radiation. So this can also be given an external beam. So sometimes this is given like somebody has a brain tumor, but maybe it's small enough where we can just zap it with a very large dose one time, and that's enough to potentially treat it. Or maybe they had a brain tumor and they had it removed and it was small enough, they just give one large dose to that area in the brain and they don't need further treatment. So that's high dose, where they get one large dose, not used as frequently. They can also use what's called brachytherapy. So this is internal radiation. So if you guys can see kind of these catheters, so they'll sometimes use this for prostate. So they have these long catheters that will be placed up into the prostate, actually poking into the tumor itself. So the male patient is laying like in stirrups, and you usually have a urologist that helps place these directly into the prostate, and then you have a radiation therapist that actually gives the radiation, okay? So these go directly in, they give like one big zap, and then these catheters are removed. They can also do this for like lung cancers. So say somebody presents to the ER and they're super short of breath, they can't breathe, they do an x-ray, they have this huge tumor that's basically occluding their airway. And if we don't get it shrunk right away or do something, it's gonna shut off their airway and they're not gonna make it, okay? So they will have a pulmonologist basically go down their throat with a scope. They'll put these catheters directly into that tumor in their lung and give high doses of radiation to try to shrink it down very quickly. So that's another example of brachytherapy. Very high risk of the lung bleeding. Some tumors are very vascular, so there's been cases where patients have had to have brachytherapy in an emergent situation, and they open up their airway, but then they end up dying from like basically bleeding out from that tumor. So those are not commonly used, it's more of emergency situations. They use it mostly for prostate cancer, to put directly into that tumor in the prostate, zap it. Usually they'll do a dose in the morning, a dose in the evening, and then the patient goes home the next day. But they have to lay that whole entire day with these catheters in their prostate. So kind of an uncomfortable procedure for one day of their life, okay? So nursing considerations, so here is an example of skin. So this would be somebody who's getting radiation to the head and neck area. People always will ask me, what do you think the worst cancer is? As far as treatment goes, if you have a head and neck cancer and you have to get radiation to any area in your head and neck, so tongue cancer, tonsil cancer, larynx, anything like that, this is awful, awful treatment to go through. They get about 6 weeks of radiation with concurrent chemotherapy, and basically their throat becomes extremely raw. They can't swallow. Their saliva becomes like glue, literally looks like Elmer's glue. It becomes very, very thick from the radiation. So sometimes it affects their speech. They can't taste, they can't swallow. These people usually end up with a G-tube because nutrition is a huge factor. So the prognosis is very good. If people get diagnosed with head and neck cancer, typically they have a very high cure rate, but the treatment is horrible. Probably one of the worst treatments, in my opinion, to go through. Because literally they are irradiating a very sensitive area, and for about a good 3-4 months, the patient's gonna go through pure hell. They can't swallow, they sometimes can't talk, they can't eat. If they can't eat, food tastes like nothing or like cardboard or metallic-y. Some patients will say like everything tastes like pure cardboard or tastes like super metal-y, so they don't eat. They lose a lot of weight. A lot of them, they'll get a tube feeding place before they ever start treatment, just because they know that this is what's gonna happen. And so as nurses, it's really hard to try to prepare somebody that, yeah, you need to go through this treatment, but you're gonna feel absolutely awful. Your skin on their skin on the outside will be red. I've seen skin that actually looks like really gets really dark in color, almost like necrotic. It never dies all the way, but it just becomes so irritated. Sometimes if they have a lot of skin problems or they're in so much pain, they'll have to give them a break in treatment because it just becomes too much. So this would be not something I'd ever want to go through or wish anyone to ever have to go through. It's pretty awful treatment. Second on my list would be rectal cancer, because they literally radiate the rectum. So imagine when you have diarrhea and your rectum hurts, imagine that about 100 times worse. So they have severe diarrhea from it in a rectum that is raw and red. So that's pretty severe too, but I think head and neck is probably the worst in my book. Anybody that gets radiation to the face or to the brain, they put on what's called a mask. So if somebody is claustrophobic, they actually bolt this to the table. So this starts out as like a very soft mesh. They put it in water and they mold it around their face. And this helps them hold their head in the exact same position every day. Because if you think about it, if they're radiating your brain and you sneeze, oh, we just radiated back here. And now we radiated healthy tissue that potentially could damage their memory, their cognition, their thinking. So they literally bolt them to the table. So if anyone's claustrophobic, if you bolted my head to the table, I think I'd have to be sedated. I could not lay like this with a mask over my face because I get a little claustrophobic. Okay? So they can have no direct sun exposure to any skin that's been radiated, just because it's already pretty sensitive. Lots of precautions. They can radiate for like breast. If somebody has implants, you can radiate. Cancer can get underneath those implants. Sometimes those implants will burst with radiation, so sometimes they'll have them taken out. Assess for claustrophobic. Educate the patient on what they should expect. So no lotions, no ointments, nothing on the skin. Women, if it's breast, they don't wear bras with metal or anything that can like rub on their skin. So to wear loose clothing, and basically to monitor their symptoms. So are they able to eat? Are they able to swallow? What is their pain like? Okay? So some assessments we're gonna do. So overall assessment, are any of their organs involved? So what kind of questions would you guys ask somebody going through treatment? Based on all that I just told you. What kind of assessments would be important? Their weight, maybe? How is their diet? How's their nutritional intake? fevers, any rashes, pain. Is their pain under control? Do they notice any new lumps or bumps? How are they coping? Okay, usually anyone going through cancer, they have a social worker or like a case manager assigned to their case to help them through some of these psychosocial issues. Okay, obviously a lot of risks for infection, risk for injury, imbalanced nutrition. So outcomes don't always include a full recovery, right? We're not gonna cure everybody. Depends on what their stage is when they're diagnosed and how they're coping with it. So pay attention to symptoms. Set goals together with the client is really important. Remember, let them be in control as much as they can. And if they choose not to get treatment, we want to support that. Okay. All right, so why don't you guys, they don't want us to come until at least a little after 12, just because they're still treating patients. So why don't you guys grab lunch, and then 10 of you meet me over there.